started. I think some more people will be wandering in, but I want our keynote speaker to have as much time as possible this morning, because I think it's a great topic and it's one that we don't get to hear about very often. So, good morning.
Good morning.
I'm Robin Miller. I'm with the Center on Disability and Development at Texas A&M. On behalf of the center and all of our organizers, thank you so much for being here, for taking part in the conference, and for all that you do to work together as a community to support all of our kids as a whole. So let's get started with quick thanks to our sponsors. Hopefully we have somebody from each one in the room. We'll start off with our gold sponsor, We Build Aggieland. Oh, there. I was looking in the wrong direction. Thank you.
Mercy. Thank you so much.
And then our platinum sponsors, we have I always put the Ben Law Group.
We used to have a D, we just took it off. So we used to have a D. Thank you.
Another platinum sponsor is Galloway Kucera Financial. And the long name, DSHS CYS HCN System Development Group. It's another of our platinum sponsors. Doing wonderful work through Department of State Health Services. And finally, at the back, I see Barbara. We have our Student Hireability Navigator and our local workforce board. This is the first year that we've recruited financial sponsors for this event, and we really appreciate your contribution. The event keeps getting larger and more complex, and your contributions are allowing us to create more and more depth and a broader reach for this conference. So we appreciate all of you. We're going to let you guys wave from where you are or stand where you are. Thank you to the members of the planning committee, both of the local school districts, the center, and all kinds of agencies and groups across the community come together to put on the conference. So if you'll stand and or wave as I acknowledge you. First off, we have some staff members from the Center on Disability and Development here. That's you, Tanya. And Marcy on her way out of the room. And Lucinda. Bryan ISD. College Station ISD. And the person waving in the back is Amy Cecil, by the way. She organized our student art display. The exhibit is to your left. Central Church, who helps us organize the event and provides the space free of charge. St. Joseph Outpatient Therapy and St. Joseph Health WellFit. When you see the Switch toy distribution that is at this far end of the exhibits, they are organizing all of that and providing that for our families, and it's a really exciting project that's new to our community. Partners Resource Network, Brazos Valley Council of Governments, and the Easter Seals. So thank you all. It takes a lot to put on this conference, and we really appreciate everyone's time and commitment and all of the wonderful things that you do to make this happen. Before I introduce Dr. Sledge, all of your bags have a little yellow card like this. This is your satisfaction survey. We have made some last-minute updates to the survey, and so instead of having printed surveys this year, we will have online surveys. It's available in English and Spanish. Please, please, please fill this out. It helps us plan our next conference, and it also helps us maintain funding so that we can continue to do this. So please, please fill it out. We will remind you throughout the day. Last bit of housekeeping, when you get ready for breakout sessions later, you'll come back through this room, through this door, or this, and all of the breakout rooms are on the hallway behind me. And now, let's introduce our keynote. We are thrilled to have Dr. Elizabeth Sledge speaking with us today. She is a board-certified pediatrician with Summit Pediatrics here in town. She is also a mother with lived experience of navigating the healthcare system and accessing services. And she uses that experience and her own interests to educate medical students, residents, and other healthcare providers about family-centered practices and disability awareness in order to create more ease of access for all of our individuals with disability in the community to a system that can be very hard to navigate sometimes. She is also uses person-centered approaches and, of course, disability awareness in her own practice, and she's here to give you some tips on how to navigate that system. So please help me welcome Dr. Elizabeth Sledge.
Thank you so much for that introduction. I'm very happy to be here. So this is a topic that I'm extremely passionate about, not just as a pediatrician, but also as a mama. So if you read my bio in the little program that you got, you know, the journey that I am on right now is not the journey that my husband and I thought that we were gonna have. But the tour guide that we have for this journey is amazing. And he has really made me into a better mother and to a better physician. And so this is I'm very passionate about this topic. I feel like I could speak on multiple different categories in this topic for days because it's hard to just kind of gently touch on all of these different things. But I'm going to try my best to kind of give you some ideas of like what our goals are in providing family-centered and patient-centered care, and just some things to help make life just a little bit easier as a parent of a child with a disability. I have no personal or professional financial disclosures. I'm a board-certified pediatrician, and I'm also a fellow of the American Academy of Pediatrics, but I'm also a mother of a child with special needs. So I frequently tell people, you know, I'm not a developmental pediatrician. I'm not an expert in the traditional sense of disabilities, but I live this. I am in the trenches every day. I have days where I'm like just sitting in my car listening to music or praying just because we've had a hard morning, and I've got to get it together before I go take care of patients. And so I kind of want to use that. I use that in my exam rooms to really to help patients and parents feel listened and heard, and then also to help them kind of feel loved. So the objectives today, we're going to talk about, you know, why is this such an important topic? So we're going to talk about how prevalent developmental disabilities in the United States are and how that affects the access to care. We're also going to talk about why the need for advocacy is so great for children with disabilities. We're going to talk about medical homes. What is a medical home and why is that so important? But we're also going to talk about helpful resources for navigating the medical care system, how to advocate for our babies, but then also talk about the school system. We're just going to touch on that just a little bit. So I graduated from Texas Tech University Health Sciences Center in Lubbock in 2013. My husband and I are both from Bryan, College Station. We graduated from Bryan High, but in 2009 we moved to Lubbock and we were there for 14 years. I did my medical school training in Lubbock. I stayed there for pediatric residency, and then I stayed on as an assistant professor and general pediatrician for 7 years until we felt like we were being led to come back home in July of 2023. My husband actually works in Bryan ISD. He's a special education teacher right now. He works at Sudbury Intermediate. So a lot of the stuff I'm going to talk about, he has also helped me learn a lot more about, just because he also sees the education side. We have lots of conversations about that in our home. But the most important experience are these two babies right here. My daughter, Ellie, made me a mom. I had her when I was in medical school, in my last year of medical school. She is an advocate herself for children with special needs, and is very passionate about making sure that all of her friends feel heard. She has ADHD, so she wanted me to mention that. She's like, you're going to talk a lot about brothers, so I want you to mention that I have ADHD and I help you learn too. And so I said, well, I will mention that. She's like, you have lots of slides about Colin. There's only one with my picture. I said, well, you were definitely a part of the story. My little boy right there, that's Colin Michael. So Colin was born at the beginning of my 3rd year of residency. And he has autism spectrum disorder. He also has some anxiety. So we have dealt with meltdowns, poor sleep, feeding issues, PT, OT, speech, all the things. So our story started with him. I had a very difficult pregnancy. I was in my 2nd year of residency, and I ended up on strict bed rest for over a month. We had a very traumatic, difficult delivery. He ended up in the NICU, and then things just kind of started to be a little bit different, just not your typical development for a child. He had torticollis, where his neck was like this. So we started physical therapy at 4 months, but then noticed that he just wasn't progressing gross motor wise, so we stayed in physical therapy. He wasn't eating well and was choking, so we started feeding therapy around 9 months. And then when he was about 15 months, we started occupational therapy due to his fine motor skills being delayed, and then also sensory issues. The boy never slept. He had some pretty significant sensory issues. We had speech delay and motor delay. He received a diagnosis of sensory processing disorder. Really, I diagnosed him. I mean, he didn't really have to go to a doctor to, but around 15 to 18 months. But both my husband and I suspected that he had autism spectrum disorder prior to the age of 2. He was speech delayed. He had echolalia. Echolalia is where kiddos repeat what you say, or they just repeat certain phrases. Colin would walk around saying, apple juice, apple juice, apple juice. My mom's shaking her head, she remembers. And he never drank apple juice, but he liked that word, and he liked the way that felt. Or I'd say, what did you do today? And he'd say, what did I do today? He'd repeat those things. Fixed interest, and I'll show you some pictures in a minute. He arranged things in a line, and God forbid I move something out of that line. He was very attached to strange items. He had a blue Duplo block that he carried around with him forever. He'd crawl, and it sounded like he had high heels on. He had very difficulty with transitions, and any change in our routine caused a meltdown. Even driving a different way to therapy. We had to stop at the post office before we went to therapy, and it caused a huge meltdown. So if I wiped his hands with a wet wipe, he would gag. If he stood in sand, certain textures, he just was not really excited about that. He loved snuggling, but only if it was his idea. So these are just some pictures. So the one right here on the far left, he loved to be in that carrier. I thought I was going to have to carry him in a carrier for the rest of his life. This was us actually at a program for his sister, a Christmas program. And the only way he would stop screaming is for me to put him in that and walk up and down the cafeteria. The middle picture is him in physical therapy. He's so cute. And then the one on the right was us working with an occupational therapist. He's putting his feet and hands in rice at that point to kind of some sensory integration therapy right there. Tell me you have a child with autism without telling me you have a child with autism. That's the title of all of these pictures. And still to this day, bless him, in our shower, he arranges all of the bottles according to height. And they all have to be facing a certain way. And if I take one out but don't put it back in, he's like, Mama, that's not where that goes. And I'm like, I know. Okay. So these, I'm not going to read all of these, but these are all of the posts. I was very good about documenting our journey on social media until I got off of social media because it wasn't good for my mental health. Just because when you're living struggles and then you're seeing everybody through their perfect filter, It was a very hard thing for me. But now I see how, when I can go back to this and I see how far we've come. But then also, I like to tell people about our story. I'm very upfront about it. I don't have everything together. And anyone that tells you that is a liar. But these are all of our posts about poor sleep. This picture right here of both of us in the recliner, this is me studying for the pediatric boards. And the only way that I could actually study, so I wasn't attending at that point. I was working full-time in a clinic, and the boy never slept. And the only way I could ever study, and he would sleep, was like that. So I studied for the boards. I don't say that, so you're like, oh. But like this is legit. The picture of the Starbucks, that's me. He didn't sleep that night, and the only way he would ever sleep that day is I would put him in the car and drive him around. Hence the other picture, this one, right there, drive around the loop of Lubbock over and over and over again with a weighted blanket until the boy slept. You can see it's 10:30 on the clock. I was at a red light. I promise I was not doing this while I was driving. Okay. And then this picture where he's eating, that was just telling people, thank God for your prayers, because he actually slept last night. And so when I'd go get Starbucks, I'd drive around Lubbock and pick out my dream homes. I'd drive around all the fancy neighborhoods and just like dream like, someday, Lord, someday my child will sleep and I'll live in a house like that, you know. So, but this is real, right? And then this is the day that we, so this was after he got his diagnosis, and I just posted a really honest, long post. And it's interesting, I went back to this recently, it showed up on a memory of Facebook, and I wrote on there that, you know, I wasn't really sure what the Lord had planned for our family, but I knew that Colin was a huge part of that. And he is. He changed my trajectory on my path to make me more passionate about the babies that really need our help, and the mamas and the daddies and the grandparents that are living it day to day. And I wrote on there that it's actually made me a better pediatrician. It's very true. Not in knowledge, but then also in wisdom, but it's also increased my empathy and my compassion, and just really opened up a whole new world to something that I didn't think was really my niche, like my passion. So we started ABA therapy, we continued OT, PT, and feeding therapy. We started ABA, which is Applied Behavioral Analysis. We started that when he was 2.5-ish. And then he was doing so well that we started the child find process, and we'll talk about what is the child find process in a minute. So we started pre-K the last week of February in 2020. So he went to school for 3 weeks, and then he was at home. We survived, we all lived, praise God, but he now attends public school that has accommodations. So this is my babies today. This is them ringing the bell at Christmas this past year. So he's not currently in private services. We probably should start doing some things just for gross motor, but we are way better than we were. I thought there was a time where I thought he would never walk. I thought he'd never talk. He didn't say mama till he was almost 2. And I remember the first time he said, I love you too. And it wasn't echolalia. That was probably around the time he was closer to 3. His feeding is better. We have chronic tummy issues. That's common in kids with autism. We still struggle with the anger and the anxiety and the meltdowns. And we have some sleep problems sometimes. We still work on social skills. You know, you don't outgrow autism. It just looks different at different ages. So each age and stage brings its own challenges. But long story short, we've come a long way. So let's talk about how to navigate the system and why this is important. So in the United States, it's estimated that there are 14 million children and youth with special health care needs. That abbreviation, the CYSHCN, the really long one we talked about. So 14 million children, that's almost 20% of children in the United States. And more than 12 million of these children, so almost 86%, do not have access to a well-functioning system. So a well-functioning system is where families are partners in decision-making, shared decision-making. It's bi-directional communication. I make recommendations to you, you tell me what your biggest concerns are, and together we're going to come up with a plan. We'll talk about shared decision-making in a minute. In a well-functioning system, children receive coordinated, ongoing, and comprehensive care within a medical home. We're also going to talk about what a medical home is. Families are adequately insured, so they have appropriate funding for their medical needs. Children are screened early and continuously for healthcare needs. Their services are organized so that families can easily use them, so the system should be accessible, both in geography, but then also just in availability, and they're satisfied. And then also, the last piece of this is where children with special healthcare needs can receive assistance, like the families receive assistance with learning how to transition from the pediatric world to the adult world. There is a big difference between the pediatric world and the adult world. Pediatricians are frequently, we get a little aggressive sometimes when it comes to our patients, not aggressive in a bad sense, but we are passionate about our babies. And so I will just pick up the phone and call you, like call the specialist or call the therapist. That does not happen in the adult world. I don't practice in the adult world, but it's hard. So in Texas, only 29% of children with special health care needs ages 0 to 17 have a medical home. 30%. And that a lot of times is just, especially in kids in rural communities, children who are in underserved populations, they just don't have an access to care. There's also a pediatrician shortage nationwide, and there's also a pediatric subspecialty shortage nationwide. That's a whole different topic. We can talk about that later as to why that's happening. But the American Academy of Pediatrics is really working hard to address that. Only 17% of adolescents with special healthcare needs receive services necessary to make transitions to adult healthcare. Now, in my practice, I take care of my babies with special healthcare needs until they're 21. I technically, as a pediatrician, can take care of babies until they're 21. I can still call them babies. They are my babies. But that transition period is very anxiety-provoking, not only for the child, but also for the family. I mean, even in our arts, where they're like, do you want to talk about future planning for your son? Like, what do you, and I'm like, that creates anxiety. Can we not touch on that topic right now? I'm a little, so I'm not alone in that. So 57%, only 57%, about half of kids with special health care needs are continuously and adequately insured. So they have appropriate funding, and that is continuous. There's no drop in coverage. And 45% of children with special health care needs in Texas live below the 200%, have a household income below 200% of the federal poverty level. So they're impoverished. So they may not be adequately insured, they're impoverished, and they have a lack of access to care. So why is the medical system so hard? Well, it's complex. I mean, I just listed, even for my son, all of the services that we needed to access, right? PT, OT, speech. We had to work with the school system. He had specialists for multiple, issues, medical problems that he's having. So not only are parents having to access therapies, possibly counseling for behavioral related issues, we're also worried about the school. We're worried about learning more about our child's diagnosis, about how to appropriately advocate for him, who's the right person to go to for this. And it's so fragmented that families are like, there's just so much. I mean, for a long time, my mom's sitting right here, but she moved to Lubbock to help us care for my little boy. And he had therapy 3 times a week, and I was working full-time in a clinic. My husband's a teacher, and so for a long time our calendar was just, I feel like it was just therapy and doctor's appointments, right? So that can become overwhelming. And not only that, but you need to access things from the private sector and the public sector. And getting everybody to communicate and be on the same page is like pulling teeth. So this is, I don't know, I'm sure y'all all have felt this way, like this. I feel like this is me some mornings, but you have multiple services, you have multiple providers in multiple sectors, in the private and the public sector, and it creates a very complicated network, and you just get overwhelmed, like, okay, when was I supposed to follow up? Okay, when is that due? And oh, we're still waiting on insurance auth for this therapy to start. I'm not really sure. So it's very expensive. It's time consuming, it's frustrating, and it's exhausting. So the system, like I said, is fragmented, and this creates barriers for families to access and enroll in services and meet their child's needs. Not only that, as physicians, we all use a different electronic medical record. It's hard to get people to communicate with one another. We're all busy, and if you're slammed in clinic, it's hard sometimes to pick up the phone or send a referral, so send appropriate documentation. But the other thing is that families frequently don't know what's available to them. So that's part of what we're going to talk about today. Like, where do you go to find what's available for you? And then we also know that if you have a child with special healthcare needs, it increases your health inequity. What I mean by that is that you're going to have it's harder to access care. And then also because of the financial strain that many families experience, because of the stress that many families experience, it also can increase the struggles that you face outside of the medical world. So navigating the system is much harder for people who are impoverished, who have a lack of food, housing, lack of transportation, and who are experiencing racism. And 45% of children and youth with special health care needs in the state of Texas live in a home that's below 200% of the federal poverty level. And then we know this, I know this, that in the family, you have a guardian or guardians who become the primary caregiver. And in children who have more complex medical needs, often caregivers have to give up their job. They have to, give up caring for themselves in order to become that primary caregiver and a care coordinator. So your job is not only to provide care, but you have to coordinate all these appointments and things like that. And there are studies that show that parents of children with special health care needs, they get divorced more often. There's more marital discord. They struggle more with anxiety and depression. They feel self-isolated, and then they also have financial strain. So how do we navigate the medical system? Well, it all starts in the medical home. The medical home does not just refer to a building or a place. The American Academy of Pediatrics states that the medical home extends beyond the walls of a clinical practice. So the medical home refers to the relationship of a primary care provider to the family, okay? It builds partnerships. So the goal of a medical home, the goal of having a primary care physician is to build a foundation of trust and a relationship that follows this child from birth to adulthood. So it also is kind of a hub that creates partnerships with specialists, families, and community resources. I refer myself, this may not be a good term, but I refer myself as the gatekeeper. Like, people come to me and I say, okay, like, I'm kind of this hub, and I send out the referrals, and you come to me for a well check. Okay, how are we doing on our specialist appointments? When's your next specialist appointment? Tell me what your medications are. Where are we on therapies? Do you need any new referrals? And so I'm kind of the gatekeeper. But a medical home also recognizes the family as a constant in a child and family's life, and it emphasizes shared decision making and the value and the role of a family in providing care. So according to the AAP, a medical home should be provides comprehensive and high quality primary care. It should be accessible, family-centered, continuous, comprehensive, coordinated, compassionate, and culturally effective. Well, what does that mean? So your pediatrician should know your child's health history, should listen, okay, should follow up with other healthcare providers your child receives care from, create a partnership with you, to make sure that your medical and non-medical needs are met. I can speak to you about your medical needs until we're blue in the face, but if you don't have food in your home, that's an issue. If you don't have a home to live in, that's an issue. Let me get you set up with appropriate resources, or let me direct you to people who can help you with that, because we know that that's going to make your medical health, that's going to make your health worse if you're homeless and you're not eating, right? But most importantly, it creates a trusting, collaborative relationship. You should be treated with compassion, develops a care plan, and then respects and honors your cultures and traditions. So shared decision making, I talked about that. So this involves two people, frequently the family and provider. If the child is old enough, I involve the child in this. I ask them, what's one thing that you really want to work on today? And you should share information in both directions. Everyone shares their concerns, their preferences, their priorities, and understands the option. And then decisions are reached together. So I wrote on here, and when you look up shared decision making, they talk about like this is used in making difficult decisions and to set goals for care. I think you should use shared decision making in every visit. So like I can tell you what's happening and what this is my recommendation, but like what's realistic and what's feasible for you. You should care starts in a medical home. You should have shared decision making, but really care and navigating the system starts early. So in the world of pediatrics, we want to pick up developmental delays and disabilities at a young age. We do developmental surveillance and then also developmental screening. So developmental surveillance is just a way for us to identify children at risk for developmental delay. It involves interviewing a parent, asking about concerns, and this occurs at every child visit and every health supervision visit, and it's continuous. I do this even when a kid comes in for a sick visit. Let's say they're establishing care with me, and they're 4, and I'm like, you're not speaking. Like, I know you're here for a runny nose today, but then also I've noticed you're not talking. Let's address that. I can't turn the developmental surveillance off. My husband thinks it's weird. We'll be at like a store, and I'm like, I think that kid's like 30 months, and he's like, what is wrong with you? I'm like, it's a party trick. I don't know. I can guess their development based on their motor skills. He's like, quit staring. People are gonna think you're creepy. So we don't just do surveillance, we do specific screeners. So a screening is when you use validated screeners at specific time periods. Now the AAP says 9, 18, and 30 months, and then you should do autism screening at 18 and 24 months. I do developmental screening at 9, 12, 15, 18, 24, 30, 36, and 48 months. We also speak in months in the world of pediatrics, not years. So, but I do those at all of those visits. But specifically, you should have developmental screening at that age. And that's a validated screener, and it helps to pick up more subtle things. So I use the Ages and Stages questionnaires. Some pediatricians use the Denver questionnaires. There are other validated screeners as long as it's validated. I use Ages and Stages. On the right is the MCHAT. And I give that to patients at 18 and 24 months. And then if they come to me a little bit later and there's a concern for possible autism, you can use it, I think, up to the age of 3, maybe a little bit later. But if it's concerning, I automatically send to for evaluation and send to therapy. So if you're concerned, if we pick up a developmental concern, a pediatrician at that point should refer to appropriate therapy services. Sometimes if it's at risk, so I'm like, maybe you need a little bit more time, I give them a list of activities and things that they can work on at home. But I'm a huge proponent of early intervention, especially in the critical periods of development. I've witnessed it in my own home, but then also that's just the right thing to do. So speech therapy assists with speech, but also can help with feeding therapy. OT assists with fine motor skills, but also can help with sensory integration issues. And some OTs also work on feeding. Physical therapy can help work with gross motor skills, coordination, and balance. And then you may need referral to a behavioral specialist that can help with emotional and social development. ECI is Early Childhood Intervention. This is provided under the Individuals with Disability Education Act. It's provided by federal and state funding, and it's for children from birth to the age of 3. It's a statewide program. Ours here in the Brazos Valley is run through the Easter Seals out of Houston. In Lubbock, it was run through Lubbock ISD. It's for children with developmental delays, disabilities, or certain medical diagnoses. There's a list of medical diagnoses that automatically qualify you for ECI services. Prematurity, like significant prematurity, is one of those, and then kiddos who have vision impairment, hearing impairment will qualify. And it's anybody can refer. You don't have to go to your doctor to refer. You can refer your own child. A neighbor can refer you. It's family-centered. It occurs at home. The biggest goal of ECI is to teach the families how to also assist and do like a home education program for them. But not only that, but they use case managers that also can identify issues with resources in the home. And so, if a family is struggling with a lack of food or financial assistance, then they can also help get the families hooked up with that. But then it also helps with transition to the next steps, which if they're older than 3, if they're in ECI and they're coming up on their 3rd birthday, they're going to start the child find process, which is where they go to the local school district and they get evaluated to see if they qualify for special education services. So if you aren't in ECI and you have concerns and you want your child to be evaluated, you can call your local school district's special education department and tell them you would like to start the child find process, or I have concerns about my child's development and I would like to have them evaluated for preschool education services. And then they hook you up with the right person. And if you talk to somebody and they're like, I don't know what you're talking about, say, can I talk to the special ed coordinator, please? So here are some resources for early development. Healthychildren.org is my favorite website of all. It's run by the American Academy of Pediatrics, so if it's on there, it's legit. And that's the same advice that I'm going to give you in my clinic. It has everything from if you're pregnant, how do you, what are some things to prepare for your child. It talks about development, nutrition, emotional development. It has lots of really good handouts for all different kinds of common childhood illnesses. It has a really good search bar. So at healthychildren.org, I frequently in my clinic, I'm like, you need to go and look this up. It's very helpful. The CDC milestone tracker app, that little picture right there is what it looks like in the App Store. It's in English or Spanish. You can have multiple children to where you're tracking their milestone. It helps you pick up on issues with possible delay. It shows you videos and pictures of what, like when they say a child should be cruising, not in a car, but like they should be pulling the stand and cruising along furniture. It shows you videos and pictures of that. It also gives you reminders of well-child visits, things to talk about with your pediatrician, and then also just prevention strategies as well. And then also the CDC Learn the Signs Act Early website is a really good resource as well. And then again, ECI. So other resources, the Family to Family Network is for individuals with disabilities and their families. They provide case management. They have information on IEP support and training. They can help with transition services, referrals to community resources, training events. They have webinars. They have lots of different things on different disabilities and diagnoses, and it can help you connect with support groups for families who are struggling with different disabilities. So if your child has autism or if your child has cerebral palsy, it can hook you up with different support groups and has lots of information on that. And this is a state website, but every state has their own. But this is a very, very good website as well. NavigateLifeTexas.org is also a very good resource. It's for families raising children with disabilities. It has information about individual diagnoses, special education information. What is an ARD? What is an IEP? What is a 504? What are my legal rights? What are my rights as a mom? What are my child's rights? Because lots of people don't know that. It also has information about financial assistance and education and insurance. So information on SSI, which is a whole topic in itself. We could spend, which I think is one of the breakout sessions. The Medicaid waiver program, transition services. Again, that's a whole topic in itself. And then also it provides family support. Care maps. There's a Care Map app that was started by Boston Children's Hospital. I have a friend who did a complex care clinic in Lubbock, and she gave care binders to each of her patients. She and a social worker and her nurse in her clinic all create care binders, and each divider is a different aspect of the child's health. So for like you have your therapies in one divider, you have every specialist has their own divider. You have a medication divider so that you can go and you can update. For Colin, I have a running document on my computer that's divided into sections, and every year I update that. And if we go to a new doctor, I don't want to have to hash out everything. I just print it out and say, here it is. Okay? You can refer to that document. I don't want to have to go over everything. But I have like medications, his birth history, his allergies, where are we now with all of the issues, and then at the top or the bottom I'll write like concerns that we need to address today. I know about that because I know what I would want as a pediatrician, but I think that's very helpful, and a lot of times case managers and things like that can help you. But Care Maps are actually, the Care Map app actually does that for you. This is what a care map looks like. So in the middle, you put the family. You put the child and the family, and then each little spoke, each little orange thing, and you can do this with paper. The Boston Children's Hospital website has information on how to do this, but each little spoke is a different aspect of the child's care. So like medical, and then each little spoke off of that is all their different specialists. And then, education is one, financial assistance is one, so that you have the name and the number of each person. This can be a little cumbersome, but I think once you get it, it's helpful. But the Care Map app, it's only in the Apple Store, but that does it for you. So you just input everything in. It's kind of cumbersome, but then it, once you get it in the first time, it's actually quite helpful. But you can also do it with a care binder. I'm very much the old school. I want to write everything down in my paper calendar, and I want a paper copy. I don't do technology. That's my husband's job. So that's the medical system. We're running a little bit behind, but I do want to touch on the school system, just because I have a lot of families who come to me. And I'll say, are they receiving special ed services? And what are their accommodations? And they're like, I don't know. I'm like, I remember the ARD, but I think they're getting this. I'm not real sure. And I'll ask them, well, do they have modifications? Are they receiving any special services at school? What's the goal? When's their next ARD? And they're like, I don't know. And that is not to the fault of the parent. The hard part is that the education world speaks the language and the medical world speaks the language, and parents are stuck in the middle, and they don't understand either one, because we paid a lot of money to use fancy words, and by golly, we are going to use those. And it's the same in the education world. And going through the ARD process with my child, I have some skills. I'm knowledgeable about some things, but walking into the ARD, I felt very ignorant and overwhelmed. And thank God my husband was there. My mom, who's a retired educator who dealt with special education, was there, so I had people who knew what they were talking about, but not everybody has that. And so the reason I want to talk about this and the reason why I do this in my clinic is because people should understand their child's education. They should understand their child's rights. And really our goal is the same, right? We speak different languages, but we're all on the same team. So the IDEA, this is the Individuals with Disability Education Act, ensures education for all children, regardless of the severity of the disability. It makes sure that every child receives a free and appropriate public education, okay? And it ensures federal funding to states for ECI, which we talked about, but also to special education and related services from children ages 3 to 21. So it also states that schools and states and school districts must ID, so identify, locate, and evaluate all children without regard to severity. If a child is eligible for special education services, then they will receive an IEP, an individualized education program. And then children should be educated with children without disabilities to the maximum extent possible. So the way that the law describes this, the term is an LRE, or the least restrictive environment. So some children may stay in a special ed classroom all day, but they come out and they have PE and art and music with peers who do not have disabilities. And that's our goal, because we want inclusion. A child with a disability by definition are all of these things. I won't go into them per the law. And then, so we talked about the IDEA idea, but we also have a Section 504. So Section 504 defines disability in general. So this is any physical or mental impairment that substantially limits a person in a major life activity, not necessarily just in education. If the diagnosis affects the educational program, then it falls under the federal law, IDEA. So it's illegal to discriminate if a school receives federal funding. So private schools are not, if they don't receive federal funding, private schools are not required to follow this, right? And it ensures that children are entitled to a free and appropriate education in the least restrictive environment. So if I have a child who has ADHD, or even I have a child who has severe food allergies, but they need some changes in their classroom environment, you could do a 504, okay? So, for example, or asthma. So let's say I have a child who has severe food allergies, but they need a 504 because they need to have a different environment where they may consume their food, or they need to require that all of the tables are wiped down before they sit there to eat that, because if they touch a table that has nuts on it or peanuts, then they can have anaphylaxis. ADHD a lot of times falls under Section 504. We have that for our daughter. So she has the ability to stand and have a sitting desk. Her desk is in the corner, not because she's being punished, but because she's 5'7", and if she stands up to take notes, she's going to impede the vision of everybody else around her. So that's why her desk is to the side. She has the ability to have fidgets. She has the little rubber bands that can go on the bottom of her desk. And so what the 504 does is it helps to make sure that children have the tools to help them be successful, and they're guaranteed that. So she stood up to take notes, and her teacher said, "You have to sit down." And she says, "Actually, no, I don't." Because all of her teachers know that. So it just guarantees them this foundation of tools. So an FIE is a full individualized evaluation. So when you request a child to be evaluated from the school district, this is what they do. It's done by a diagnostician. You may have a PT, OT, speech do that. They may have they have a psychologist. Some school districts have what we call LSSPs, which are licensed school psychologists. And then you can have some schools, they employ clinical psychologists. However, just know that smaller school districts are going to have limited resources and may employ people from outside. and they may have limited resources. They're still required to provide special education, but they may have limited resources on what they're able to provide. Essentially, an FIE, I describe this as a very long consult note. In the medical world, that's what it is. So if I ask a neurologist to consult on a patient, it's their assessment of the deficits or the strengths or the weaknesses of this child. And then after you do an FIE, everybody comes together. We have something called an ARD, which is the admission, review, and dismissal. It occurs after the initial evaluation, but then every year for review. But a parent has a right to call an ARD at any time. So if a parent and I have a conversation about their child is struggling, and I said, when was their last ARD? And they said it was 3 months ago. We're not scheduled until the end of the school year or next year, but they have some issues. I said, I think you need to call for an ARD. I think there are some things that maybe we need to change. It's very sticky. If I call the school district and say, I think you need to make these accommodations, I will, and I have. And I've written letters of medical necessity, but that would be the equivalent of them calling me and saying, please put this child on medication, which happens sometimes. But again, we are all a part of the same team. And so I may say, I really think, if this child is having meltdowns every morning in the cafeteria because it's loud and they don't have the accommodation to go somewhere else or to a quiet classroom where they don't have the accommodation to have headphones, let's call for an ARD, let's just get that in there. And maybe we won't be flipping our lid every time you drop them off at school, which comes down to asking about the context of behavior. So the committee meets with the parents and the child. We review the IEP, but this is a very overwhelming process, and I don't know any of you in ARD, do you feel like this? If you walked into a room, the first one that we experienced with my son, there were legit 15 people in the room, and they all stare at you. And I was taking notes, and they were like, Mrs. Sledge, we're going to provide you with a copy of this. And I was like, oh, that's nice. I said, oh, that's nice, but I'm going to take notes myself. Yeah. And I'm going to ask some questions. Yeah. Again, my husband was there, my mom was there, we had people from the Autism Academy in Lubbock to help advocate for things, but not everybody has this. But this is overwhelming, and this is why when parents come to me and I say, what did y'all talk about in the ARD, they're like, girl, I don't know. I think I was there. I think we talked about this, but I don't really remember. Because there's 12 people looking at you. And they're all talking about your child. And sometimes they talk about the strengths, but they don't always talk about that, right? And so you feel overwhelmed and you don't know what to ask for and you don't know what to advocate for. So I'm guessing all of it is clear as mud. When you start talking about IDEA and 504 and FIE and IEP and LRE, again, the education world speaks a different language. So just some things. Partners Resource Network is a nonprofit that runs the Parent Training and Information Centers in Texas. So the Individuals with Disabilities Education Act provides federal funding for PTIs, or Parent Training Information Centers, statewide. So in the state of Texas, we have 4 of these. Brazos County is in Education Region 6, and so our PTI for Brazos County is the PATH project. If you just Google Partners Resource Network, go to their website. It is very, very helpful. They can help you understand your child's disability. You can just call. It's free. It's provided for by federal funding. You can say, I don't really understand. What are my child's rights? I don't understand what an ARD is. I'm very overwhelmed, and they can help answer your questions and help you understand that a little bit better. And they explain the law in plain language on that website. So it's a very, very good website. So they can help participate as team members in planning services for your kid. This is the website. So, like I said, it has information about special education law and about the special education process in general. How do I even start this? This is very overwhelming. It has information about various disabilities. It has online courses. It has webinars that you can look at. And Navigate Life Texas that we talked about before also has important things about that, and then they also explain the law in plain language. So what is my role? Okay, well, first of all, prevention. So doctors discuss, like, when you're pregnant, how do we prevent things with, how do we prevent issues in babies? Because we know that prematurity, there are certain things that can put babies at risk of having developmental issues, developmental disabilities. One, we want to talk to you about not smoking, not drinking. Please don't do drugs whenever you're pregnant. We encourage vaccines because we know that many vaccine-preventable illnesses, like pneumococcal vaccine, measles, can cause issues with the brain. It can cause encephalitis. It can cause meningitis. So we want to vaccinate you to prevent illnesses that can increase your likelihood of having developmental disabilities. And we want to recognize those early, which is why we talked about developmental surveillance and screening. We also want to evaluate for other causes of problems with academic progress. So if a parent comes to me and says, my child is really, really struggling in school, the teachers think that he has ADHD, and so I just ask a lot of questions. Maybe you have sleep apnea, and you're not sleeping at nighttime, and so you're falling asleep at school, and that's why you're not paying attention. Maybe there's a lot of trauma going on at your home, and you feel like you're being chased by a tiger all the time. That's why you're not paying attention. Maybe you can't read, and you're in 4th grade. I had a child like that once before. The school was like, he's just not paying attention and he's causing problems. And when they did an FIE, his reading level was equivalent to a kindergartner. They were giving him 4th grade work. I said, I'm not going to give him medicine. The problem is that he can't read. Maybe we need to help him with that. And so there's a lot of things that look like other things that are not that. So what I mean by, like, not everything that struggles to pay attention or that everything that has a meltdown or hyperactivity is because they just want to be difficult and don't want to pay attention. You have to understand behavior and context. So we want to, if we identify a problem, we want to refer you to the school, we want to refer you to the appropriate therapist, I want to refer you to the appropriate specialist. If I'm worried you have sleep apnea, I want to get a sleep study, let's send you and let's get you fixed up for that. So treatment if needed, if you need medication to help you in school, we can have that conversation. Again, we'll do shared decision making. I want to advocate as a pediatrician, so I want to not just advocate, like, I want to advocate for you in the medical system, but I also want families to understand their child's strengths and challenges appropriately. So, especially in cases of ADHD, if the family's like, they're so difficult. And I'm like, they're really trying. We're trying. Let's try to understand, like, one, what are they really good at? What are they really passionate about? But then also, like, understand this is a challenge for them too, right? They don't want to get up and run around all the time. Like, their brain is just wired differently. But then we also want to facilitate further evaluation if needed. So that's my job. So that was a lot. I'm sorry we ran a little bit over, but I felt like it was very important that we covered all of those things. I'm happy to answer any questions that you may have. I have a table, Summit Pediatrics out there. My husband is also there. Like I said, he's special ed teacher and has a degree in administration, so he understands the special ed world a little bit better than I do. Frequently I ask him questions. I'll say, I read an IEP for my kid. What does this mean? My sister is also a special education teacher and my mom's former administrator, so a lot of times I'll text him and say, I read this in an IEP with no patient information, but I'll just say, what does this term mean? Just so that I can understand. But thank you so much for letting me speak, and I can answer any questions that you may have.
Thank you again, Dr. Sledge. We are just so fortunate to have you here. Thank you for all the information that you shared. A couple of quick reminders. When it's time for breakout sessions, they're in the hallway right behind us, so we're about to open up these doors. Remember to use that QR code to fill out our survey. And I didn't I wasn't able to be here to hear all of the resources that you mentioned, but one of the ones that you mentioned is Partners Resource Network. They are on our planning committee, and they do have a table here, so they're a great source of information. They're in our cubby hole around the corner. We got relocated because of renovations for the church. So if you come out and go to the right and then take a left just before you leave the building, there's a whole hallway of booths on that hallway, and that's where Partner Resource Network is. Thank you so much, and thank you again, Dr. Sledge.